Hello, you are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Gynaecomastia. Yes, we are still in the era of anatomy of clinical importance. And my friends, this is today's case study. A 23-year-old young man presents with bilateral enlargement of his breast after chronically abusing anabolic steroids for greater muscle mass and enhanced muscular features. As a result of the increased muscle mass, he became a bit depressed and withdrew from colleagues and friends in the society. As a result, he decided to seek medical help from the hospital. So this is a case study before us, and we have some questions to go through. Now, the first question is that based on the presentation of this individual, what is the most likely diagnosis? Yes, already we said that he has bilateral enlargement of his breast. So clinically, what's the term for it? And my friends, your answer is gynaecomastia. So gynaecomastia is your answer, okay? Now, question number 2. What are the features, okay, as far as the breast of this individual is concerned, that are consistent with gynaecomastia? So your answers should be these. Number 1, of course, physically we can appreciate that his breasts are enlarged. That's from the first one, enlargement of the breast. That's the first one. Number 2 is that yes, the breast will be tender. Okay, as far as whenever you palpate it, yes, there will be tenderness of the breast. And then also the nipple, okay, will be highly sensitive. So increased sensitivity of the nipple is also a consistent finding. That's point number 3. Now number 4, the highly pigmented area around the nipple, and that's the one we call areola, okay, will also increase in diameter. So the diameter or the circumference, as far as the areola is concerned, yes, will increase. And then also, if you look at this individual's chest, okay, there will be that kind of asymmetry. So chest asymmetry, okay, will also be a consistent finding as far as gynaecomastia is concerned. Well, now there are some individuals, now those are not a consistent finding, but there are some individuals who present with gynaecomastia and they also have, a prolactin secreting tumor. In such case, you see that there will be that kind of discharge, okay, that kind of milk may be coming out of what we call the nipple area, okay. So that is not always something that we find, but it may also be present, okay. So these are the findings that are consistent with gynaecomastia. Now, the question number 3 for us is that now we have a condition that is called pseudo-gynaecomastia. And in pseudo-gynaecomastia, we see it especially in obese males. So if an obese male, okay, tend to have what we call pseudo-gynaecomastia instead of gynaecomastia. And so we want to understand the clear-cut histologic, distinguishing feature between pseudo-gynaecomastia and true gynaecomastia. And my friends, your answer is that in pseudo-gynaecomastia, already we said that the individual is obese. And so the real histologic finding that will be consistent with pseudo-gynaecomastia is the presence of increased adipose tissue. Okay, as far as this individual's breast tissue entirely is concerned, increased adipose tissue, the fat content will increase. However, in the case of the true gynaecomastia, it doesn't have to do with increased fat tissue. Rather, it has to do with increased glandular tissue. And so by way of the secretory sinus of the breast, together with, of course, the duct system of the breast will increase, will become enormous. Okay, so that's the clear-cut histologic finding between them. Now, fourth question is that if we have seen that this individual is suffering from gynecomastia, we said that it was due to, abuse of anabolic steroids. What explains this finding? Meanwhile, initially, the initial idea was to have, greater muscle mass and then also present with, of course, enhanced muscular features. Okay, so what is the case in here? The reason is that now steroids, just like the male hormone testosterone, yes, the predominant male hormone, in females we talk about estrogens. What we see that these are steroid hormones, they are made from cholesterol. And so when you take in anabolic steroids, the idea is that if you are a male, then we are going to use this anabolic steroid, okay, to produce more testosterone. Now, if you are producing more testosterone, okay, the body does not need it so much. And so what happens is that the excess testosterone will have to be aromatized, will have to be converted to become estrogens. So whichever estrogen we are talking about, whether E1, E2, E3, E4, it will be converted to estrogens. And once we produce these estrogens, okay, one thing we will see is that you fail to manifest a lot of the masculine features. Rather, you'll be having a lot of the feminine features. And that is why one of that feature that we will also be seeing, which will be the next question which I'm going to ask you, okay, is that apart from, yes, looking at all these features, the feminine features of the breast, what other features, okay, will also be manifested as far as this individual who has chronically abused anabolic steroids is concerned? And my friends, your answer will be that there will be what we call testicular atrophy. Now, the testes of the individual will become smaller. Now, the reason is simple. All the male masculine features that we want to see, they rely on what we call testosterone. And so once testosterone levels have gone down, because in gynecomastia, okay, what we will be seeing is that the testosterone level, the ratio of the estrogens to testosterone, okay, will increase. So estrogen level will go up slightly, while testosterone level will decrease slightly. Okay, that's what we'll be seeing. And so for this reason, because the testis is a male organ and it relies on testosterone for its, development, for its growth, then what we are going to also see is that we will see that there will be testicular atrophy. The testis will decrease in size. Well, not only that, even the penis will decrease in size. Also understand that males, and for that matter even females, libido, as far as sexual arousement is concerned, yes, one thing is that we rely on the hormone testosterone. And so for this reason, this individual's, libido will be decreased drastically. That's also under, constant finding that we find in individuals with gynecomastia. Well, because also the penultimate step as far as spermatogenesis is concerned, that is spermiogenesis is concerned, we rely on what we call testosterone. Okay? Now, you want to, at the end of the day, yes, we want to convert this spermatis, okay, to eventually become functional spermatozoa. We need testosterone. And here's the case: the testes have undergone atrophy, okay, and then we are not getting enough testosterone from the Leydig cells. Then therefore tells me that what will happen is that we cannot produce functional, spermatozoa. And for this reason, this individual may have some kind of infertility issues. Yes, not only that, this individual may also even have a lot of, buttocks will be enormous. Okay, the gluteal region will increase in size. Now, the reason is that estrogen, whenever estrogen levels go up, okay, what we see is that it helps you to retain a lot of the fat. Okay, so there will be a lot of adipose tissue accumulated in your gluteal region. And so that is why these individuals will present with some of these, manifestations. Now, good. Now, the fourth question for us is that what will be the endocrine findings as far as someone with gynecomastia, yes, is concerned? And my friends, whenever we talk about endocrine findings, we are talking about in terms of hormones. And so what are these things? The first thing I need you to understand is that the hormone, yes, we know that there will be what we call reduction, so to speak, as far as the testosterone level is concerned. Okay, and then of course the estrogen level will increase slightly. Okay, that's what we're seeing. Now, individuals whose gynecomastia is due to something called primary hypogonadism, Okay, and whenever we talk about primary hypogonadism, it has to do with the problem with the testes. Now, here is something I need you to understand. We have something we call hypothalamus and pituitary gonadal axis. Okay, that's a three-level system. Okay, as far as these hormones work. So one thing that we understand is that if it is secondary hypogonadism, then the problem will have to do with the hypothalamus or the anterior pituitary gland. But if it is primary hypogonadism, then it has to do with the problem with the testes. Understand that if it is secondary hypogonadism, what we understand is that the hypothalamus, okay, in your brain will secrete something called GnRH, okay, gonadotropin releasing hormone. And that releasing hormone will have an effect on the anterior pituitary gland, stimulating it to produce what we call the gonadotropins by way of, follicle stimulating hormone, FSH, and then also LH, luteinizing hormone. But I prefer that in males, we don't call it LH, we don't call it luteinizing hormone, we call it ICSH, interstitial cell stimulating hormone. The reason is simple, because at the end of the day, when this LH, so-called, let's put it in this case, or in this case, ICSH, interstitial cell stimulating hormone, okay, will have an effect on the testes. Which area of the testes? The Leydig cells of the testes. And the Leydig cells of the testes, they are the interstitial cells of the testes. And that's why this hormone LH, I prefer we call it ICSH, interstitial cell stimulating hormone. Why? Because they are going to stimulate the interstitial cells of the testes. And who are those guys? The Leydig cells. And what are they going to do? They are going to secrete what we call testosterone. And once they secrete the testosterone, then we know that, what is going to happen, helping with the muscular features and all that. But here's the case. We are talking about primary hypogonadism. Then the problem has to do with the testes. So there's no issue with, GnRH. There's no issue with anterior pituitary secreting what we call ICSH. So the problem has to do with the testes. The Leydig cells of the testes, being stimulated to secrete what we call the testosterone. And so that becomes your primary hypogonadism. In that case, another endocrine finding that you may see will be increased ICSH, increased interstitial cell stimulating hormone, which of course you can also call, luteinizing hormone, LH. Okay, that's also another thing that we see. Now, one more thing that some individuals tend to also see, okay, is that we also talk about, increased prolactin level, hyperprolactinemia. That is not really a consistent finding, so to speak. It is only seen in individuals, especially those with prolactin secreting tumors. Okay, that's when you may see another thing like that the prolactin level may increase. Okay, so that's one thing I need to understand. And that is when such individuals may be seeing secretions coming from, of course, the nipple of the breast. So now the next thing is that we've seen, this case. The other thing that we need to also understand is that are there other conditions? We said this individual abused anabolic steroids. Are there other things that one may do, other conditions that may predispose one to suffering from this, what you call gynaecomastia? Yes, the answer is yes. And what are some of these conditions? Now, there could be some kind of chronic conditions. And what we mean by these chronic conditions, especially, we're talking about liver disease, kidney disease, okay, even an issue with the thyroid gland. These things can predispose one to suffer from some of these things. If you have a condition where, of course, there are some tumors and they secrete a lot of the estrogens, okay, that could be also one of the things that one may, have, which may result in some of these, conditions. Already, I've told you about secondary hypogonadism, okay, saying that what we talk about a problem with the pituitary gland, talking about problem with, of course, the hypothalamus. So it's an issue over there, then it may have some of these manifestations, okay. Now, one more thing that I need you to understand is that even individuals, okay, who engage in some kind of illicit activities like smoking marijuana is one of the things which can predispose one to suffer from some of these gynaecomastic, conditions. Okay, so please understand some of these, dynamics. And there are some medications one may take and may have some kind of issues like some of these things. And so whenever you are taking a medication, and I don't want to mention any name, but whenever you see some of these changes, then you may want to seek that kind of redress from, of course, your primary health provider. And that's why you have some of these things like going for review and all that. You go and explain some of these things. Now, understand that whenever we're talking about this gynecomastia, it could be physiologic, so to speak, especially when you have a newborn. Okay, so immediately after birth, after coming out of your mother's womb, because of the high circulating levels of estrogens of your mother, okay, through the placenta and all that, one thing that we realize is that, yes, one may be born or in the first few weeks may present with some kind of gynecomastic, conditions. Okay, and that gynecomastia usually will resolve in about maximum of 2 weeks. It will resolve. Okay, now also if we are trying, now that one we see it in about up to about 70% of the cases. Okay, we talk about 60 to about 69, up to 70% of the cases of these newborns may present in both males and females. Okay, it's a common thing that we see. And then also when you are transitioning, yes, around the puberty, adolescent stage, you may have some of these issues because of course the fluctuations and of course the estrogens and the testosterone levels. You may have something, but usually it will resolve in a maximum of 2 years. It should resolve. But if it doesn't resolve, that is when we go to, of course, the management, and we come to that one. And then also, especially in about 35% of the cases, individuals around 50 to about 69 years, let me say up to 70 years, they may also have, especially they are prone to some of these gynecomastia that we are talking about. Very common thing that we see. So it tells me that whenever you are in such a situation, you are not the only person. The only thing is that, as I mentioned, there are some emotional issues. There are some, of course, as I mentioned, social withdrawal, okay, some kind of depression and all that, okay, low self-esteem and all that, because you find yourself in some of these situations, okay, and that is why there will be the need, for us to, of course, help with some of these management issues. And so, my friends, what will be the management issues as far as gynecomastia is concerned? Yes, it could be direct observation. As I said, there are some individuals who could be physiologic. Okay, well, other things that it could be idiopathic. Yes, we don't know, we cannot explain, okay, what really accounted for that. Cannot explain. And so we need to just give a close observation and see what will happen, that whether it will resolve in no time or not. Now, sometimes there may be the need for some kind of medication, like giving you tamoxifen will help, because this tamoxifen, for instance, is what we call, an estrogen receptor antagonist. So it will help, okay, reduce the chances, so that, yes, we know estrogen is helping with the proliferation of the breast tissue, so that, yes, it reduces drastically. But my friends, sometimes there will be the need for surgical intervention, and that is something we call reduction mammoplasty. Okay, so that will call the breast tissue, enormous tissue that we find over there. Some could be taken out. Yes, it's not only applicable in males, even females also. If your breasts have become so heavy, weighing you down, giving you a lot of, back pains and all that, issues with the spine, then there may be the need, okay, for you to remove some of these things. Yes, sometimes regarding some of these self-esteem issues and all that, okay. And of course, sometimes because of that, some people withdraw from, of course, eating. They may have some kind of eating disorders. So maybe they need, okay, to intervene with, of course, this surgery. My friends, I believe you find this meeting helpful. I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.